Today's topic is PSMA-targeted PET imaging and radioligand therapy in the management of prostate cancer. I'm Dr. Bella Dennis. I head up medical affairs at Lantheus, and it's my pleasure to introduce you to today's presenter, Dr. Stephen Rowe. Dr. Rowe is being compensated and or receiving an honorarium from Lantheus in connection with his presentation. The content contained in this presentation was developed solely by Dr. Rowe. All slides, thoughts, and opinions are those of the speaker. In my introduction, I want to give you a little short bio on Dr. Rowe. Dr. Rowe obtained his MD and PhD in chemistry from the University of Michigan before undertaking training in diagnostic radiology and nuclear medicine at Johns Hopkins. He was on the faculty at Hopkins for 7 years before moving to the University of North Carolina last year. In his current role, Steve continues to pursue research in molecular imaging of genitourinary malignancies with a focus on the role of PSMA PET in prostate and other cancers. As we start this webinar, I want to remind everybody that if you have questions, please put them in the chat and direct them to Ginger Warner. Ginger Warner will then forward them to Dr. Rowe at the end of his presentation. We should have some time to take a couple of questions. Steve, I'm going to turn the microphone over to you.
Thanks so much, Bella. I really appreciate the introduction. It's a genuine pleasure to be with everyone today. PSMA PET is something that is near and dear to my heart, and I'm going to go ahead and share my slides while we're at this. And not only because, as Bella mentioned, that Lantheus compensates me for talking about this, but I believe that I was the first person to ever inject an agent called PYLARIFY into a human subject. And I remember meeting the guy. We injected him. We saw all sorts of sites of disease that hadn't really been visible on conventional imaging. And there were a bunch of high fives and hugs. And I remember thinking, this is probably a really momentous time. This is maybe one of the most interesting things I'll ever be a part of. And when I saw that same patient a couple of years later for his standard of care restaging bone scan, I had remembered him. He had kind of an unusual name, and I thanked him for this for agreeing to participate in that original clinical trial, and that it was a really important sort of watershed moment for men with prostate cancer. And the guy looked at me and said, "What thing that I volunteered for? I have no idea what you're talking about." So clearly, what had been sort of a momentous occasion for us kind of missed the mark, perhaps, with our very first patient. Nonetheless, I would stand by my thoughts that day that was a momentous watershed moment in the history of prostate cancer. And here we are a number of years later, probably 10 or so years later, with multiple agents that are FDA approved, including a therapeutic agent, and lots more things in the pipeline that are going to come out over the next few years. So with that, I'll kind of launch into my talk. So I do have a few slides of sort of compliance things, basically just stuff to I'll really quickly go over regarding specifically PYLARIFY, and then we'll go into a little bit more freewheeling part of the talk, which is going to be things that I have specifically to tell you. It'll start with a brief introduction into molecular imaging. Then we'll talk about sort of what we know about PSMA PET and what we know about PSMA-targeted radioligand therapy. And then I do want to spend a few minutes going over some of the things we don't quite know yet, and things that I tend to get a lot of questions about, like response assessment. So that'll be kind of the plan, and so we'll go ahead and get started. I'll mention one last thing. I'm on clinical service today, so you may hear a phone occasionally ringing in the background or something like that. But just it goes to show I'm just sort of a workaday Joe like everybody else. So I think you've heard that, and you've heard that. And I do have a couple of disclosures. As you can see here, the one that's relevant is Progenics Pharmaceuticals, which is a wholly owned subsidiary of Lantheus. All right. So, and again, I'll go through kind of the boilerplate slides fairly quickly because I think we do want to talk about some of the particularly exciting things, again, that we both know and will hopefully one day know about PSMA PET and PSMA-targeted radioligand therapy. So very specifically, Pylarify or piflufolastat F18 is a radioactive diagnostic agent indicated for PET of PSMA-positive lesions in men with prostate cancer. There are two labeled indications, and we'll go over where both of these come from in future slides. Men with suspected metastasis who are candidates for initial definitive therapy, and men with suspected recurrence based on an elevated serum PSA level. There are no absolute contraindications to the use of Pylarify. In terms of warnings and precautions, there is a risk of image misinterpretation. Imaging interpretation errors can occur with Pylarify imaging. Negative image does not rule out the presence of prostate cancer. Positive image does not confirm the presence of prostate cancer. The performance of Pylarify for imaging of patients with biochemical evidence of recurrence of prostate cancer seems to be affected by serum PSA levels. The performance of Pylarify for imaging of metastatic pelvic lymph nodes prior to initial definitive therapy seems to be affected by risk factors such as Gleason score and tumor stage. Pylarify uptake is not specific for prostate cancer and may occur with other types of cancer, as well as non-malignant processes and in normal tissues. Clinical correlation, which may include histopathologic evaluation of suspected prostate cancer site, is recommended. Additional warnings and precautions: hypersensitivity reactions. Monitor patients for hypersensitivity reactions, particularly patients with a history of allergy to other drugs and foods. Reactions may be delayed. Always have trained staff and resuscitation equipment available. In terms of radiation risk, diagnostic radiopharmaceuticals, including Pylarify, expose patients to radiation. Radiation exposure is associated with a dose-dependent increased risk of cancer. Ensure safe handling and preparation procedures to protect patients and healthcare workers from unintentional radiation exposure. Advise patients to hydrate before and after administration and to avoid frequently after administration. In terms of adverse reactions, most frequently reported adverse reactions were headaches, dysgeusia, and fatigue, all occurring at rates of less than or equal to 2%. In the clinical studies were done with Pylarify and then submitted to the FDA. In addition, delayed hypersensitivity reactions reported in one patient with a history of allergic reactions. Drug interactions, ADT, and other therapies targeting the androgen pathway, such as androgen receptor antagonists, may result in changes in uptake of Pylarify in prostate cancer. The effect of these therapies on performance of Pylarify PET has not been established. We, again, are going to come back to that idea of how we might use PSMA PET in response assessment. But again, do want to throw this idea out there. And then if you did need to report an adverse reaction, there's numbers and websites on the slide. All right. So you'll notice a switch back to the sort of North Carolina blue colors here. So this is sort of back to my de novo slides, and we'll start in with again a brief introduction to what molecular or functional imaging is. And this is from the Society of Nuclear Medicine Molecular Imaging. So the molecular imaging is a type of medical imaging that provides detailed pictures of what is happening inside the body at the molecular and cellular level. Now, that doesn't really tell us much. What do we actually need to be able to do molecular imaging? Well, we need a tracer, and it's going to be most often a small molecule or antibody, and we'll usually have a radionuclide label, hence it will be a radio tracer. You can do molecular imaging with other kinds of tracers, but radio tracers are what we use clinically, and what you'll certainly encounter the most, and what you're going to be hearing about today. Now, those radio tracers can read out a few different processes in the body. We can imagine having a metabolic radio tracer, and that's our most common agent, F18 FDG, which is essentially radioactive glucose, and so it goes to tissues and processes where glycolytic metabolism is occurring. But we can also imagine doing targeted radio tracers, and that's what we have with the small molecules that target PSMA. They bind to the active site of PSMA and hence localize to prostate cancer in that manner. When we talk about molecular imaging, or when maybe you hear folks in the nuclear medicine field discuss things, they will usually break these molecular imaging agents or radio tracers down into a couple of broad categories. They're positron emission tomography or PET agents, and single photon emission computed tomography, or sort of single photon emitting agents or SPECT agents. Now, we're only going to talk about PET today, so I'm not going to really bore you with the details of SPECT. I will just say that PET is really the premier molecular imaging modality. It has a higher spatial and contrast resolution than we can achieve with SPECT. There are lots of important applications of SPECT, but again, PET is what we're going to be focusing on today. With PET, we have what are positron-rich radionuclides. Proton-rich radionuclides. Those undergo a decay event. They give off a positron, which is a form of antimatter. That form of antimatter will go out, find an electron within regular matter to annihilate with, and it produces two 511 keV photons. And those are actually what we pick up with the with the detector, and that they come off in an approximately 180-degree fashion. And so the detection of two events on a PET detector ring that are approximately 180 degrees apart is what really drives the contrast and spatial resolution and relatively low noise characteristics of PET images. Now, if you're used to looking at CT, you'd say a PET image still looks really noisy, and that is true to an extent. But there's no practical limit to the amount of radioactivity that we can get into a small structure. So the contrast resolution of PET allows us to resolve things that we can't resolve based just on spatial resolution, which is all that something like CT has going for it. There are a couple of different families of radionuclides. There are the organic atom-like things, which we tend to use a lot in today's clinical practice, in F-18 being the most common radionuclide that we're using with PET. But there are also radiometals available. And of course, in the PSMA world, gallium is something that is relevant. I won't really talk about that. Let's move on to PSMA and really get into the heart of what we're here to talk about. So PSMA is a transmembrane carboxypeptidase. It's highly expressed on prostate cancer cells. Frequent expression has been observed in prostate cancer tumors, and about 96% of prostate cancer tumors are going to express amounts of PSMA that's at least that we can at least assess by immunohistochemistry. Vast majority of those are going to be tumors that we can also see in vivo in patients with PSMA PET imaging. And then there's some sort of a correlation between expression levels and tumor aggressiveness that is probably off. We probably often don't observe that at sort of the macroscopic level on a PET scan, but that's something that the histopathology folks can tell us, that when they see higher levels of PSMA expression by immunohistochemistry, that those tend to be worse tumors. Again, PSMA is a transmembrane carboxypeptidase. It has a large extracellular domain, including the folate hydrolase active site, and that's actually where PSMA small molecules, both for imaging and for therapy, bind. So we've been investigating PSMA PET in humans since somewhere around 2011 or 2012. So we've had actually quite a number of years to figure some things out about it, and we have pivotal phase 3 clinical trials in multiple contexts that tell us things as definitively as we're ever likely to know them. So we know that PSMA PET has moderate sensitivity, but very high specificity for preoperative nodal staging in men with higher NCCN-defined higher, very high-risk prostate cancer. We know that it has high detection efficiency for sites of biochemical recurrence, and we know it's effective for guiding focal therapy, or metastasis-directed therapy would probably be a better way I could have put that, and also for selecting patients for PSMA-based radioligand therapy. And so where do those ideas come from? Let me show you the progression from maybe some sort of early phase, single center phase 2 studies to those pivotal phase 3 clinical trials. Here are two patients. These two gentlemen were imaged, I want to say sometime around 2014 or 2015. And when they agreed to participate in this particular clinical trial, both men were clinically localized, NCCN-defined high-risk prostate cancer. So they were both offered the same therapeutic options. They both went through sort of a very similar discussion at a multidisciplinary conference. But ultimately, they wound up getting these PSMA PET scans. The patient on the left side of your screen, after that PSMA PET scan, he's clinically localized still. We only see uptake in his prostate, which is that red arrowhead below the bladder. And in fact, he did go on to surgery. He achieved a negative PSA, or undetectable PSA, and at least a couple of years afterwards had actually not recurred. So one of the sort of success stories of a high risk patient undergoing surgery and then potentially being cured. The patient on the right, however, had unsuspected what you might call micrometastatic or occult metastatic disease that extended not only into pelvic lymph nodes, but also retroperitoneal lymph nodes and a left supralambicular lymph node. Now, because this trial was actually a blinded trial at first, this patient also went to surgery, but as you might imagine, had immediate biochemical failure. So even though these patients were the same, according to sort of our clinical impressions of them and conventional imaging findings in them, they were nonetheless radically different. And so one of the real powers of PSMA PET is that you can correctly bend patients into into a more nuanced clinical category and then offer them the right therapy at the right time for those patients. Findings like that eventually led to the Osprey trial, and we'll focus on Osprey cohort A, which ultimately included 252 evaluable men who all underwent surgery with an extended pelvic lymph node dissection. Though the results of those pelvic lymph node dissections were compared to histopathology for sensitivity and specificity for pelvic lymph node involvement, and those were the co-primary endpoints of the Osprey trial, specifically of Osprey cohort A. When you break everything down, Osprey cohort A ultimately did miss its sensitivity co-primary endpoint. So the sensitivity was about 40%. The expected sensitivity that was discussed before starting the trial was 60%, with a lower bound of the 95% confidence interval at about 40%. So that was a missed co-primary endpoint. However, when you look at the specificity, it's shockingly high. It's as close to 100% as generally anything we're ever going to see in medicine. Now, when you do a post hoc analysis, which admittedly this was not the agreed upon uh, co-primary endpoint with the FDA. So I'm not trying to put one over on you or anything. I just want to show something interesting that happens when you limit the analysis to only those lymph nodes that are at least 5 millimeters in short axis. Your sensitivity goes up to 60%. Your specificity stays exactly the same. So unlike almost anything else, there's no sensitivity specificity trade-off here. The specificity is always super high. So we have to read the pelvic lymph node stations in these patients with an exquisite sensitivity, looking for very subtle things, knowing that no matter how sensitive we are, our specificity is rock solid. And if we call a lymph node as positive, it is going to be positive in histopathology, almost certainly. All right, let's move on from initial staging to biochemical recurrence. So here was a patient who had restaging CT and bone scan following a rise in PSA after a prostatectomy, did not have any findings on that. We did a PSMA PET scan on him. We found this tiny little focus of uptake behind the bladder. So this is to emphasize that bladder activity isn't the end of the world, that you just have to be very diligent. You have to look in these places that are right next to that radioactivity window aggressively to try to uncover these subtle findings, and then look very carefully around the bladder neck anastomosis. Nonetheless, the oncologist that was treating this patient actually didn't believe us that this was a real finding. So they did a dynamic contrast enhanced MRI of the pelvis, and there's an enhancing nodule in that location, which verified that this was the patient's site of recurrence. The most common pattern that you'll encounter on PSMA PET in terms of the biochemical recurrence population is one or perhaps two small lymph nodes in the pelvis. And so this is the most common pattern. A local recurrence is the second most common pattern. And quite honestly, everything else becomes rare after that. The apparent strength of these agents in biochemical recurrence led to the idea of doing a multi-center phase 3 clinical trial, and that was the Condor trial. It consisted of 208 patients, none of whom had informative conventional imaging, and I think that's an important point. Conventional imaging in this patient population had a 0% detection efficiency for finding sites of disease. The patients in Condor also had a tiered hierarchical standard of truth that all lesions that were found on PSMA PET went through. And I won't go into the details of that, but it was hopefully a well thought out standard of truth. As you might imagine, the detection efficiency in Condor tracked fairly strongly with PSA levels, where at PSA is less than 0.5, the detection efficiency was somewhere below 50%. I think the 36% is probably a little bit pessimistic relative to what we can achieve at the single center level. But nonetheless, that was what was found in Condor. And then when you get to PSAs greater than 5, you approach 100% detection efficiency. Where this becomes interesting is if we look at the actual primary endpoint of Condor, which is something called the correct localization rate, or essentially positive predictive value at the lesion level. Here you can see that the positive predictive value is actually robust across different PSA levels. So again, what this means for us on the scan is that while there are going to be a fair number of scans at low PSAs that are negative, if there's a finding that makes sense for prostate cancer in those low PSA patients, the positive predictive value of that finding is robust, and we should feel confident about calling it. All right. So this is a patient. So if we take our I apologize for the little highlight up there. I was probably reminding myself to go back and actually change those units to nanograms per milliliter. But if we assume that everything is true with what we know about the detection efficiency and biochemical recurrence, we should be able to go one step further and say if we think that sensitivity is so high, we can perhaps select men with low volume metastatic disease, treat them with metastasis-directed therapy, and if not cure them, we can at least delay the time that they have to go on to systemic therapy and have the associated toxicities. Here is a patient, he had a solitary site of visible disease in a presacral or perirectal lymph node. That was treated. He did not start systemic therapy. His PSA became undetectable and actually remained undetectable until the IRB on this study ran out. We also see the opposite end of the spectrum, where a patient may look like they have low volume disease on some combination of CT and bone scan, such as this patient who had a ostensibly normal CT scan. He had what was thought to be maybe a metastasis in one rib, and then a bunch of degenerative and traumatic findings on his bone scan. However, when he's imaged with PYLARIFY PET, all of a sudden there are hundreds of lesions packed into his bone marrow. So, and that made more sense with his PSA, which was over 100. He almost certainly had widespread metastatic disease. Almost certainly wasn't a good candidate for metastasis-directed therapy, but we were able to confirm that with a more sensitive imaging test. This is another patient whose post-prostatectomy had a PSA of 10.9 nanograms per mil. Sorry again about those units. But he had a bit more disease visible on his scan. So he had pelvic adenopathy. He also had retroperitoneal adenopathy. And you can see that tracking up the left side of the retroperitoneum towards the left kidney. He received SBRT to those nodes. Unfortunately, on his follow-up PET scan, he actually had disseminated, relatively subtle, but disseminated bone metastases. You can also see that his PSA continued to rise, almost doubling in the 3 months between the first scan and the second scan. So there's clearly something about certain patients that makes them a better candidate for metastasis-directed therapy versus others. I don't think we understand all of those factors yet, and we probably still have a lot to learn along those lines. We're still at the point of having essentially prospective phase 2 data in the metastasis-directed therapy PSMA era, but we don't have that sort of pivotal phase 3 trial that has made this a standard of care as yet. So there are, of course, limitations to PYLARIFY and other PSMA PET agents. So we do want to be aware of those. One of them is neuroendocrine prostate cancer. So unfortunately, if a patient does develop that phenotype, then they will generally lose PSMA expression, and we may not be able to image their disease adequately with PSMA PET anymore. This really makes it incumbent upon your local radiologists or nuclear medicine physicians to be sure that they're scrutinizing the CT that comes with the PSMA PET CT. There are things that are going to be bright on the scan that aren't cancer. One of those is our non-pathologic fractures. So old rib fractures can have PSMA uptake. Here you see a compression deformity in a patient with a PSA of 0.2 that appeared on serial PET scans, but had a morphology that was consistent with a compression fracture and not with a site of prostate cancer. There are structures that have normal variant uptake. Here you can see dorsal root ganglia, celiac ganglia, stellate ganglia. Those can all have uptake on a PSMA PET scan. Here's another example of sort of lines of cervical dorsal root ganglia going down to the stellate ganglia. Stellate ganglia can be mistaken for supraclavicular lymph nodes. Celiac ganglia look just like a retroperitoneal lymph node. And so again, it's sort of a pathognomonic location that folks need to be aware of. And then maybe the bane of my existence is what to do with and how to manage sort of bone lesions that maybe don't make sense within the clinical context of the patient. This is a patient who had a PSA of 0.4. He had a local recurrence, which I'm not showing you here. He also had a bone scan that said he's got a MET that takes up the entire sacrum. He had a CT that was read as a MET taking up the entire sacrum. And his PSMA PET scan did line up there, but we were fairly convinced that this was going to wind up being Paget's disease. And you can see on the MRI that the sort of fatty marrow signal is actually preserved, suggesting this is not an infiltrative process. This is a process that is much more consistent with Paget's disease of bone. Post-radiation changes can show uptake, particularly if a patient's had, say, radiation to the brain parenchyma. Obviously, that's going to be relatively rare, but that cortical laminar necrosis, that breakdown of the blood-brain barrier, will lead to uptake of PSMA agents. All right, let me move on to a little bit about the therapy. So again, we said that we know there's a modest sensitivity but very high specificity for lymph node involvement in primary staging. We know there's a high detection efficiency in biochemical recurrence that allows us to then potentially leverage PSMA PET as a means for selecting patients for metastasis-directed therapy. There's also then, again, those patients who are going to eventually reach metastatic castration-resistant prostate cancer and have widespread metastases. Can we basically change out, say, our F18 radionuclide for a lutetium-177 beta-emitting radionuclide and treat patients? And it turns out we can, and we can do it effectively. So if we look at the number of patients that have an objective biochemical response, despite being all being metastatic castration resistant and most of them being post-chemotherapy, we find that about 40% of patients will have that objective biochemical response. We find that about 70% of patients will have any biochemical response. That does, of course, mean that 30% of patients are primary refractory to this approach. And that effectiveness comes with relatively limited toxicities, at least with the lutetium variants of our therapeutic molecules. There will be some patients some low percentage of patients that may have a little bit of a nephropathy after therapy, generally going to be sort of a self-limited grade 1 or 2 nephropathy. High-grade nephropathies are decidedly uncommon. And same thing with xerostomia. Although some patients may have a transient xerostomia, quite honestly, you give them a little bit of a sour candy to suck on if they start to have that symptom, and it'll resolve. So these are again going to generally be grade 1 and 2 self-limited toxicities. These aren't going to be sort of life-altering toxicities. So effective, well-tolerated. This is really a great therapeutic choice for our patients that, again, fall into that metastatic castration-resistant in the U.S. post-chemotherapy space. And of course, we have the VISION trial results. This was lutetium PSMA-617, or again, Pluvicto, either with standard of care or versus standard of care alone. And there was an overall progression-free, overall survival, and time to symptomatic skeletal event-free survival advantage to the addition of lutetium PSMA-617. So this made Pluvicto a standard of care, and I think our field is still kind of catching up with that because there are probably a lot of men out there that should be getting treated with this that just don't have access to it yet. There were some supply chain issues early on. There's just simply not enough nuclear medicine physicians in the world to get this agent out to everyone that can benefit from it, but we're trying. All right, so let's talk about some emerging ideas. So I think it's important to recognize, even though we've seen really nice sensitivity and specificity numbers in different contexts, that it isn't all about that. It's about harnessing the power of the scan to predict how the patient is going to do. So we need those predictive biomarkers, and they may come from a combination of imaging findings and clinical data. We absolutely need an improved understanding of lesion quantification, be that repeatability, radiomic features, and then, of course, AI, right? The looming thing that thinks is going to run all the radiologists and nuclear medicine physicians out of business. I hope it doesn't in the immediate term, but you know, it's going to impact every aspect of our lives. So we certainly would expect it to actually be a really important part of PSMA PET going forward. So let's touch on all of those areas. So the first is the idea that sensitivity and specificity aren't everything. So as we've hit on a couple of times now, that moderate sensitivity in preoperative staging, if you take a look at those patients that are false negative on the scan, true positive at histology, and you compare them to patients that are true positive on the scan and true positive at histology, the patients who had a false negative scan do better. So you might say, well, that's terrible. You're missing disease. We are, but those patients must have lower volume disease, and so they have longer biochemical recurrence-free intervals after their surgeries than patients who are true positive on the scan. So again, I think this is really tantalizing to believe that we can derive much more important information out of the scan than simply sensitivity and specificity. This is a post hoc analysis of a trial called Oriole that selected men for metastasis-directed therapy on the basis of their conventional imaging, but also obtained baseline PYLARIFY scans. And what we see is that in those patients in whom the PYLARIFY scan and the conventional imaging were concordant, those patients do really well. They have long progression-free survival and distant metastasis-free survival periods, whereas those patients who had additional disease on the PSMA PET relative to conventional imaging, those patients don't do very well. Again, that's intuitive. And I think currently the de facto thing that we're all doing is we're using PSMA PET to select patients who are metastasis-directed therapy. We're certainly not sort of relying on CT and bone scan for that anymore. We know that they're inadequate. But exactly where to incorporate PSMA PET, how to sort of do our decision making, what volume of disease, how many sites of disease there can be. All of those things are sort of an unknown or a gray area, or we sort of know, but we don't have real definitive evidence yet. Let me start getting into response assessment, because I think that's where we're going to see a lot of the sort of advanced imaging features and where we're going to leverage AI to really help us, because it turns out that this is incredibly complicated when we're using any agents that target the androgen axis, be that ADT, abiraterone, enzalutamide, darolutamide, anything that shuts down androgen signaling does strange things to PSMA expression. It looked early on like it was going to be easy. So this was the very first case. It's from Tom Hope's group at UCSF. And they imaged a patient, they gave him ADT, imaged him again 2 weeks later, and all of a sudden he has new lesions that are visible. His existing lesions are hotter. And I think all of us were totally geeked about this, right? Because this means a couple of things. One, we can potentially give patients a shot of ADT and then improve our sensitivity for sites of recurrent disease, especially in those low PSA patients where findings may be really subtle. And you can imagine then taking this and before you give Pluvicto to a patient, make sure they're kind of maximized on their ADT to really ramp up that uptake and treat those tumors better. Unfortunately, there wasn't sort of a larger case series that was immediately published after this, because it turns out it's actually very heterogeneous. The flare phenomenon that was seen is actually a heterogeneous flare phenomenon. So let me tell you about a couple of studies that have maybe tried to address things within that. The first was a two-center single-arm study of patients who were imaged with PYLARIFY PET, received abiraterone or enzalutamide, and then 2 to 4 months later were imaged again with PYLARIFY PET. And the data were so ugly, we almost couldn't approach this in any rational way. Some lesions got hotter, some lesions got colder, some lesions got more obvious, some got less obvious, some got bigger, some got smaller. And we didn't really, and all of those changes were happening within patients. So if you take a look at, say, the first patient who's in the first row of images across the top, lots of his lesions got hotter, but some of them didn't. Lots of his lesions became smaller, but many of them didn't. New lesions appeared. And we again really didn't know what to do with this. And quite honestly, it took us so many years of not wanting to face this data that we were eventually able to tie it into overall survival and potentially start fishing out some of those imaging biomarkers that we've hit on in terms of how the patient is going to do with both with the therapy and in terms of their overall survival. So we developed a couple of just arcane metrics. These are not anything like what an AI algorithm might provide you, which is going to be potentially much more nuanced. So I'm a big fan of AI in this space and what AI is going to do. I would say that these markers serve their purpose, but again, they were somewhat arbitrarily chosen. But what they are is they're metrics of overall change in tumor burden from baseline to the follow-up scan. Here's just a waterfall plot showing changes in a PSA relative to relative to sort of a qualitative abstraction of those quantitative metrics I showed you on the previous slide. But those quantitative metrics did work a little bit. So we're able to stratify patients by time to therapy change, which was sort of a surrogate for progression-free survival, because sometimes patients were continued on therapy despite having evidence of oligoprogressive disease. And those metrics were also could also stratify patients by overall survival. So again, I guess it was a blessing in disguise that this data was so complicated that we sat on it for long enough that again we were able to have that overall survival data. But I don't believe these metrics are by any means, in any way, shape, or form, some final answer to what we really want to know, which is, how can we use these changes both on a baseline scan and serially over time to predict how patients are going to do, to predict when they need a new therapy. Those things are being widely studied, but we still have a long way to go. And what I have started to see in my own clinical practice from some of my referring colleagues is when patients are going to go on a clinical trial, sure, they get a PSMA PET scan, but they're also getting CT and bone scan at baseline so that they can meet sort of the qualifications for that trial, looking at sort of RECIST metrics for response or progression. And that's so unfortunate to me. I really do hope we're getting in an era where PSMA PET is going to be our go-to for monitoring patients while both on standard of care therapy and on trials. Let me show you maybe a little bit happier story of where PYLARIFY PET was highly associated with findings in a small group of patients, but I think an important group. So these were patients that were on bipolar androgen therapy, which of course is impossible to sort of keep track of patients using PSA, because their PSA is going to spike every time they get that supraphysiologic testosterone dose. This was 6 men. They were all imaged with PYLARIFY immediately prior to starting their bipolar androgen therapy, and then after 3 cycles, which was about 84 days. And then we evaluated early progression relative to conventional imaging. You can see here, actually, this had some similarities to that abiraterone and enzalutamide cohort. Some things got hotter, some things got colder, some things disappeared, some things appeared. But if there were definitive new lesions that showed up in a patient, at least one definitive new lesion, then all of those patients met progression criteria earlier on conventional imaging than the patients who didn't have new lesions appear. Eventually, all of those new lesions we were seeing on the PYLARIFY PET were recapitulated with CT and bone scan, but it took longer to find them. So I think we found an early biomarker for how patients are doing, but this is only 6 patients, and we really need bigger studies in this to be able to state these things with the confidence that we'd like. I think it is easier with radioligand therapies or with maybe cytotoxic therapies in general. If the volume of disease is getting smaller, those patients are doing well. If the volume of disease is getting worse, those patients are doing worse. So it does become a lot easier. You don't have that heterogeneous flare phenomenon to contend with. Radiomics. So I have very mixed feelings about radiomics. You'll hear a lot about it. It's sort of advanced quantitative metrics. They're supposed to be a great way to discover new imaging biomarkers. But I will tell you, there are fundamental problems with PET scan, with PET in general as a modality, not necessarily specifically PSMA PET, but PET in general with radiomics. So I'm by no means a medical physicist, but this is how it was explained to me. The reconstruction matrix in PET has certain missing inestimable parameters within it. And those parameters are typically high frequency parameters. And most radiomic parameters are very dependent upon high frequency features. High frequency features are inestimable on PET. And that's why the images are blurry, right? You don't have those hard lines like you have with CT. If those things are inestimable, they are not reproducible, they're not repeatable. So although there's thousands of papers on radiomics and PET with imaging biomarker discovery, I think most of them are probably false discovery, and there really again isn't sort of an obvious way to apply most radiomic features to PET. When you look at radiomic features that aren't dependent upon high frequency findings with or high frequency features within the scan, such as entropy or homogeneity, these kind of broader whole lesion um, categories of radiomics, then those do become reproducible and repeatable and are probably reliable. But that's really where we need to focus our time in terms of radiomics. Uh, Again, are all radiologists out of jobs? I hope us smart ones that are going to adopt AI and plug in via Neuralink or something to sort of supercharge our ability to interpret the scans. I hope that there's a great place for us at the interface of all of this. For right now, we're already at a point where AI is helping with lesion classification, whole body tumor burden assessments, and being able to find those prognostic or predictive biomarkers. It's already a pretty good hotspot detector. Polarify AI is actually FDA cleared for this very purpose, but this doesn't necessarily get into the lesion classification, which is a much harder sort of stickier wicket, I guess you might say, to do, and is hard for human radiologists and hard to have great gold standards in this space. So that's perhaps why it's taking us a while to really sort all of that out. I think there's really interesting things that we can do with sort of a combination of advanced modalities and advanced visualization. I show this as one of my last couple of slides, mostly because of the shock value, just how cool these images look. But this is something called cinematic rendering, which uses basically the techniques that Pixar uses to create cartoons. It uses a global lighting model that creates photorealistic 3D images. Here, the PET signal is also internally lit, so you're able to sort of see it with a separate character from the CT data, which would include the skeleton, the liver, the lungs, et cetera. And although this is based on the underlying raw data that comes off of the PET CT scanner, it also adds something. So the pixels that you see here are all composed of voxels that have been that contain different amounts of different tissues or different signal, and the visualization is therefore an abstraction of that raw 2D data or raw volumetric data. So it's possible that you could, for instance, use images like this with powerful graphics processing units to actually perform AI on slightly different data that may tell you something different. So I'm sort of excited also to see where things like this head in the future. So, in conclusion, there are already multiple indications for diagnostic PSMA-based imaging. There's also now a great indication and hopefully more indications in the future for our therapeutic PSMA-based radioligand therapies. We're just starting to understand PSMA-targeted PET findings as imaging biomarkers, and AI is going to play a super important role in where we go from here, especially in biomarker development. But I'm not so convinced about radiomics. That's maybe a controversial take, but again, what I think is supported by the data and the underlying physics of the modality. I'd like to think about a million different people who have helped with obtaining data, fixing slides, helpful discussions. You can see that this is by nature a multidisciplinary concept, right? So it's not just radiology. We need urology. We need radiation oncology. I've certainly worked with a lot of medical oncologists. The data that we generated with them isn't really in this slide deck, but also medical oncology. And then of course nothing happens without funders. With that, I will thank you for your attention. And let me check and see if anything has come in the chat, and I will see if I'm able to answer any questions. Don't see anything in the chat yet, but and hopefully we touched on what some of the big questions are. Again, I think that response assessment is a huge sort of unmet need in the field, and we really do need big prospective trials. We need funding agencies to get behind that being important. I can see someone like ECOG Akron or SWOG or one of these big oncology groups. They seem like a great place to sort of fund what may be a relatively difficult trial, but is absolutely necessary. our AI algorithms are really good, but there are still some struggles. And so let me give you maybe one example of that. Uh, PSMA PET, particularly with Polarify, in my experience, has an unbelievable dynamic range. I have called lesions that have an SUV max of 0.8, but you'll see lesions that have an SUV max over 100. It is really hard, I think, for one algorithm to subsume all of that to be able to, say, segment, identify, and characterize one of these screaming hot lesions, but also find that really subtle pelvic lymph node. So that may mean that you need multiple different AI methodologies. It may mean that you need sort of generative AI, some of these newer, GANs or variable autoencoders or some of these new techniques that that may be able to address some of the shortcomings of, say, a traditional AI convolutional neural network or something like that. So there's a lot that we need to do with AI. We've only scratched that surface, but again, I do hope that I hope that we get there. And and so yeah, I it looks like nothing's come through on the chat yet. Everyone's probably sick of me talking, so I'll quiet down and thank you once again for your attention, and really do appreciate the opportunity to join you this afternoon.